Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about bleeding disorders in the human body. When I left off last week, I was talking about a condition called DIC, disseminated intravascular coagulopathy. Now, DIC basically also falls into the category of a platelet disorder, even though it's much more complicated than that. It is, in fact, an extremely complex and complicated conditions. And I'll try to describe it to you as best as I can, but it's not that easy to do on television. Be that as it may, disseminated intravascular coagulopathy, DIC, can develop because somebody has a severe infection called sepsis, or they can go into septic shock, or they have major trauma, or they were bitten by a snake, venomous snake, or by venomous spider, or what have you. The list is really quite long of what can cause someone to have DIC. Now, the first indication that a patient may have DIC, if you're taking care of them, and most DICs occur in the hospital setting, even though there's a few people walking around with it because of some chronic issues that I'm not going to get into, would be you will notice that the platelet count is down, is low. And you can say, well, the platelet count is low, it may just be the infection that the person has, which is probably could be true, but you have to do much more than that. If you suspect DIC very, very early on, you might be able to intervene quickly enough to prevent the devastation that this particular condition can cause. Now, if you see that your platelet count is low, then the next step would be to order the partial thromboplastin time. And if that also comes back low, because you had a baseline one that was normal when you just admitted the patient, now the red flag should go up. Now the third thing you need to do to try to confirm that would be to go to the laboratory and look at the patient blood smear. You actually have to do that. You can't just ask the lab to do it for you. You have to go and take a look at under the microscope. And of course, few doctors do that nowadays for reasons that I'm not going to get into, because there was a major case that occurred in New York. A young woman died at the hands of some trainees at the hospital in New York City, and they had a committee that was set up, so-called a commission, so-called Bell Commission, and they issued this report that has prevented young doctors in training from having anything to do with the laboratory, which is a horrible mistake, terrible mistake. But I'm just one physician. There are several 100,000 plus physicians, and I hold no particular power. It was a bad decision because the doctors who were trained the last few years know nothing about what goes on in a laboratory, unless they're used to work in a laboratory for other reasons, doing research or whatever. So when you look under the microscope at the blood smear, you're going to see very few platelets. But you're going to take a look at the red blood cell. You will see a lot of fragmented red blood cell, because one of the things that DIC can cause is a condition called microangiopathic hemolysis, micro-MI. And what happens there is the fact that what causes DIC to be so bad is why you're looking at the blood smear. But let me explain to you why it is important to look at the blood smear. When one has DIC, throughout the body, in particular the smaller vessels, arteries, arterioles, etc., because the abnormality that set off the DIC syndrome result in the coagulation pathway to become overactivated, and here you have bleeding and thrombosis going on at the same time. And the thrombosis is occurring with little clots and forming inside the blood vessels. So as the red blood cells are attempting to pass through these vessels, they get injured, and the injury results in microencephalopathic hemolytic anemia, fragmented. It's basically can't get through. They can't pass through. They're forcing their way through the vessels to try to deliver oxygen to the different organs. Can't do it effectively. And that's where DIC is so dangerous. So when you're looking at the blood smear, you see the fragmented red blood cell called schistocyte. Right away, you know you got DIC on your hand. It may be very early or it may be very late. We don't know. But the important thing is that then you have certain steps you have to make on how you go about managing the patient. Now, and really massive DIC, what you have here, you can have what's called multiple organ failure syndrome. Multiple organs failure syndrome. That is, because of the clogging of these vessels that go to the brain, to the heart, to the liver, to the bowel, and throughout the body, blood cannot get through effectively because of coagulation problem that you are coagulating, as it were. The blood cannot get through, and these organs will fail. So that's where most people die of DIC, not because they bleed to death, because we can give them blood, red blood cell transfusion, to try to calm things down until we treat the underlying condition that's causing the DIC. They die because they develop multiple organs failure. And it's specifically because blood cannot reach these different organs effectively. So the patient can go into coma, the kidneys can fail, the heart, they can have a heart attack, the heart can develop congestive heart failure, you name it. Eye problem, they can have all these problems. Ischemia of the extremities, all these things can happen because of DIC. So the first thing that will become abnormal will be the platelet, followed by the elevated partial thromboplastin time, and then you got all sorts of problems. Then the patient is likely to be bleeding all over the place because the platelet is going to keep dropping, and you have one part of coagulation is too high, that can cause bleeding. Another part is causing the clogging of the vessels. That's why DIC is so complicated. It really is not something that one really should even be discussed on television because it's so hard to describe. It's pages and pages of thing that you have to go through to figure this out. It's very difficult. Now, point is, if you have DIC, what do you do about it? Well, the patient is bleeding. You say, well, why don't the platelet is low? Why don't you give the patient platelet? Can't do that. Say, no. The coagulation factors drop, as it were, that causing the PTT to be high. Well, give them fresh frozen plasma. Can't do that either. Say, but why not? Well, the more fresh frozen plasma you give, the more this process is going to go on. The more platelet you give, first of all, the platelet will be destroyed almost instantaneously, and the more, it's just like you have a fire and you're pouring gasoline on top of it, which makes no sense. So that's why DIC is such a major problem. A lot of folks that you hear die in a hospital setting, at the end, many of them wind up with DIC, and the DIC plays a major role in the cause of their death. Very frequently that happens. And on the other hand, if somebody has kidney failure, acute kidney failure, having nothing to do with DIC, that itself can cause DIC to develop, and so on and so forth. Somebody has a bowel problem. The bowel becomes necrotic. It wasn't gotten to fast enough to remove the necrotic part. That itself can trigger DIC. I mean, I can go on and on talking about that, but it is a very bad thing to have developed. And the key thing is to be proactive enough so that when you have patients who are actively sick in a hospital, CCU, ICU type setting, or for that matter on the floor as well, you're monitoring their blood. Don't just file the laboratory result away if you see that the platelet is dropping. You have to troubleshoot it, find why. Why is the platelet dropping? Even though, I must tell you, however, the number one cause of low platelet in a hospital setting is not DIC, it's just the infection. Infection is the number one cause of low platelet in a hospital setting. What do I mean by infection? Well, infection does not always mean high fever and chills. You could still be infected and don't have any of these symptoms. You have to know how to evaluate someone for infection. It's not always elevated white cell, fever, chill. That's easy to figure out. It's not always like that. It's always very complicated to do other things that can indicate somebody has an infection or not, etc. So be that as it may, that is all really I'm going to say about DIC, which brought me to another condition, that is cirrhosis of the liver. I'm not going to discuss cirrhosis per se. I did that last year. There are some shows on the, if you go online, dralcena.com, you could see all these shows on the internet. The point is, when you have cirrhosis of the liver, there are many reasons, hundreds of reasons that can cause somebody's liver to become cirrhotic. We know about alcohol, we know about hepatitis B, we know about hepatitis C, we know about hepatitis E, so on and so forth. We know about HIV, all this other stuff. But once the liver becomes cirrhotic, it doesn't matter what caused it, really, because it is cirrhotic. And as part of the cirrhotic syndrome that's going on, there's a tremendous inflammatory process going on non-stop. That inflammatory process, when it becomes chronic, it scarred inside the liver, the scarring, and then the vessels inside throughout the liver, many of them, become obstructed because of the chronicity of the inflammatory process. Once you have that, because of the blockage of the blood flow inside this vessel, you have what we call the portal system becomes abnormal. You have elevated portal pressure. Once the portal pressure becomes abnormal, that then is going to cause the spleen to become enlarged. Once the spleen becomes enlarged, then you're going to wind up with pancytopenia, namely low platelet, low white blood cell count, and low red blood cell count. And then, of course, the patient can bleed, which is why I'm talking about it, for the bleeding part of it. The patient can bleed because the platelet is low, and also the coagulations products are abnormal. You have to understand that all the coagulation products made in the body, all the factors except one, are all produced by the liver. So when the liver is sick, the liver cannot produce these factors, so they become low, and the person have coagulopathy because these things are abnormal. They can bleed very easily. The factor that is not produced in the liver is factor 8. And factor 8 is produced in the wall of the large blood vessel throughout the body. All the other factors are produced by the liver. So you can bleed because of that. So that's where the bleeding part of it comes in as it relates to cirrhosis. Cirrhosis is a very complicated subject. I've done several shows on it, I believe last year. That's not what I'm talking about in this segment. I just mentioned cirrhosis so that you understand that the cirrhotic liver eventually causes elevation of the portal pressure. The portal pressure then causes the spleen to become enlarged, and you have splenomegaly. And then because of that, it's sucking up the platelets, sucking up the red cell, destroying them, and destroying the white blood cell as well. So you have what's called pancytopenia, meaning all 3 cell lines are abnormal. That is really all for me to say as it relates to the bleeding part of cirrhosis, dealing in particular with the platelet. This is how the platelet becomes low, and once the platelet becomes low, one can bleed for it. Keeping in mind, as I stated last week, I'll mention it again, it is very unlikely that somebody is going to bleed spontaneously from low platelet unless it falls below 20,000. However, if the person is challenged with trauma or surgery or whatever, or being caught in any other way, then the person obviously is going to bleed because the platelet is low, the coagulation profile is high, then you get yourself all sorts of problems. Now, that is all as far as platelet goes, because there are at least a dozen more platelet conditions, low platelet conditions, abnormal platelet conditions that I'm not going to bore you because they exist, but they're not very common. Suffice it to say, I know about them, I list them. Okay, I have a book coming out soon. It's going to be in the book, etc. Now, another common bleeding problem having nothing to do with platelets, so I'm shifting now from the platelet issues that I've been talking about the last few shows to now begin to talk about coagulopathy. That is, people who bleed because there's a certain factor deficiency they have that causes that to occur. Most of the time, those are inherited. So, which is going to bring me to talk to you about hemophilia. Okay? Hemophilia, you have two types. You have hemophilia A, you have hemophilia B. They're both inherited via X-linked recessive trait. Those are X-linked recessive trait, meaning that the abnormality is found on the X chromosome. Men have one X chromosome, women have two. So that is why all these hemophilias I'm talking about, you're likely to find them in men. So hemophilia altogether across the world, there are about 400,000 folks across the world who have hemophilia in general. 80% of them have hemophilia A, which is much more common than hemophilia B. In this country, you have some 18,000 folks that suffer from hemophilia, and 20% of that number, of course, are hemophilia B. Okay, 18,000, and I think I have the number here. Altogether, it will be 3,600 folks who have hemophilia B. The rest of them have hemophilia A of the 18,000. Now, what happens? Well, people with hemophilia, it's a bleeding disorder. It's a very severe bleeding disorder. In the hemophilia A, the factor 8 is low. It's low. And of course, in the men that have that one X chromosome, and the abnormality is in the X chromosome. That's why men who inherit this wind up with hemophilia A as well as hemophilia B. Women have two X chromosomes. Even if they were to inherit the abnormality on one X chromosome, they have a good X chromosome to protect them so they don't manifest the disease. They can be carriers of hemophilia B, but they don't themselves have hemophilia B as such. Hemophilia is very, very problematic because people bleed profusely. And of course, the way you evaluate it will be to take a history from the patient. He will then tell you about bleeding, bruising, bleeding from the nose, bleeding from the gum, bleeding in the stool, bleeding when the person urinates, and of course, you don't want to know that somebody's going to bleed into the brain, but it can happen, which is why you try our best to avoid that. So you take that history from them, then you will examine them. After you complete your physical exam, then you proceed, of course, to order some blood tests. Well, you will do a prothrombin time, you will do a partial thromboplastin time, you will do a CBC, you will do a chemistry profile, and you will proceed to do a factor 8 level. Factor 8 level. Then, of course, you do urine analysis because there may be blood in the urine. You check the patient HIV status because people who have hemophilia may have been exposed to blood product that can cause the transmission of the HIV virus, which is less frequently these days because of the new product that are being used to treat these folks. But when the AIDS epidemic just came out, a lot of people with hemophilia wind up contracting HIV from the product that they were using to stop the bleeding. That is less likely these days because the products have been improved in a way so that they are HIV free. You do ferritin level because of the recurrent bleeding, they're likely to have iron deficiency. You type their blood type because they're likely to need blood transfusion. And you check them for hepatitis A, hepatitis B, hepatitis C, etc. You check them for syphilis. You do a VDRL because, again, with a recurrent transfusion of blood product, people can contact syphilis that way. And then once you establish that the patient factor VIII is low, then the next step would be, of course, to treat them. Okay, and the treatment basically that's available this day, you have factor VIII concentrate material, which has been treated in a way so that they don't have all this hepatitis stuff in them. That is hepatitis A, B, and C, and E for that matter. And they also don't have syphilis in the product, and they don't have HIV in the product either. And then, of course, you will treat the patient with factor VIII concentrate, depending on the severity of it, that decides how frequently they get this material. And if the patient is anemic, naturally you treat them with iron product, and or if bad enough, you have to give them blood transfusion. But in the process of doing that, you also have to screen them, as I mentioned before, for all the hepatitis A, B, C, E, so on. Now, way back, a couple of weeks back, I did a series talking about ITP, not ITP, Van Willebrand disease, and at which time I mentioned a product called desmopressin. Well, believe it or not, desmopressin is used very effectively in people with hemophilia because hemophilia A, because when you give somebody desmopressin, it increases the level of factor VIII, sometime up to 15%. That is the reason why we give it in people who have Van Willebrand. Now, the DAVP or desmopressin can be used and are being used in people with hemophilia A for minor surgery, such as tooth extraction, etc. So, because it has the ability to raise the level of factor VIII. So that's what, and then hemophilia is a serious, serious disease. It's a lifetime condition. There's no cure for it. There's only treatment, as I just mentioned. And that's what hemophilia A is. And of course, as I stated before, across the world, 400,000 folks, 400,000 people have hemophilia. 80% of them are hemophilia A. Now, hemophilia B is also a recessive, is inherited in a recessive way as well, on the X chromosome as well. That's hemophilia B. So again, when somebody presents, you suspect that they have hemophilia B because they're bleeding or excessive bleeding from different procedures or spontaneously. They'll seek your help. And then you will refer them to the hematologist. You go to the same process I just mentioned for hemophilia A. You will take the history, you do a physical exam, and then you will do the same test pretty much, except that, I mean, you do a prothrombin time, you do a PTT, which is the partial thromboplastin time. You will do the CBC to examine the platelet and as well as the red blood cell level. And of course, you will check the urine, make sure there is no blood in the stool. You do all this stuff, then you will order a factor, because you see the partial thromboplastin time is elevated in both hemophilia A and hemophilia B. So to know what's the cause of it, then you would order both things. If you don't know, you will order factor VIII level, you will order factor IX level, and whichever one comes abnormal, that's your diagnosis. That's how it's done. Even though you have to keep in mind that the partial thromboplastin time can become elevated in many, many, many conditions. It's not every time that a factor, the PTT, is elevated, it's the reason of a bleeding problem. Don't be fooled by that. Because if you have lupus anticoagulant, which is a clotting disease, and the partial tumoral placentime in this condition is elevated. I mean, I don't want to confuse you, but those are very, very difficult, tricky concepts to grasp and understand, and the whole bleeding issue involving hematology is fascinating, stimulating intellectually, and actually fascinating. You know, okay, so it's pretty straightforward, really. You do all these tests, factor 9 comes low, patient have hemophilia B, and then you proceed to, again, give them factor 9 concentrate product to treat it. Now, you could always use fresh frozen plasma in a pinch until you get your hands on the actual product. There's enough factor 9 in the fresh frozen plasma, as well as there's enough factor 8 in the fresh frozen plasma to tide the person over until you get your hand onto the real stuff. The problem is that the fresh frozen plasma is more likely to transmit an infection, even though the blood banks are taking all kind of precautions these days to avoid that. But that's what we try to stay away from. That's what caused people during the beginning of the HIV epidemic to wind up with hepatitis as well as HIV, because they were getting fresh frozen plasma, etc. Those are very complicated products. I'm introducing them to you, to a complicated subject. I meant to say I'm introducing them to you so that you know if you have bleeding issues, please seek the help of your physician, who will then refer you to a hematologist so you could be evaluated properly. Listen, I'm stopping here. Until I see you again, this is Dr. Alcena saying so long and bye-bye.